This is a question for Dr. Vinnick. It said, have read a report that showed tumors develop a strategy that overcome angiogenesis. I think he's referring to the drug Sutent by increasing metastasis. The research is in animals. Do you know anything about it? Read a report that showed tumors develop a strategy that overcomes anti-angiogenesis.
Okay, it's a really important issue because I've showed you the data on progression-free survival, and I also showed you the overall survival data. What I haven't shown you is the individual data related to what can happen. There's no doubt that the drug itself works on the three mechanisms that I showed you. It works best on tumors that have a big blood supply. And that you heard from Dr. Waltering. So that neuroendocrine tumors are classic for their big blood supply. So when they metastasize to places like liver, they've still got a very big blood supply. But now that we're going for longer periods of time, these tumors metastasize to other places like bone. And in situations like that, bone or in the brain, they don't have a big blood supply. So what we're beginning to see is, as we keep people going longer, is that the tumors that have a big blood supply disappear. But we don't get control of those tumors in sites that don't have big blood supply.
Yeah.
The other thing that you need to know is if you look at the data, when we looked at a tumor and we looked at 5 or 10 drugs and the effect of that drug on angiogenesis in the primary tumor is different than the lymph node, is different than the liver. So that's part of the strategy, is if you want to make sure that you can take over a town, if you're an army, you want people dressed like peasants and people dressed like doctors and people dressed like lawyers to infiltrate the town to take it over.
Yeah.
I mean, that's part of the strategy, is everything responds to something different. One drug doesn't kill everything. I think tumors and blood vessels are very smart that way. But in the old days, there was actually a whole group of people who thought that every blood vessel in your body was the same because the blood supply in your toe is contiguous with the blood supply in your brain. That a red blood cell that's in your toe 10 minutes from now can be in your brain or in your ear or your little finger. So all the genes had to be the same, and that's just not true.
Well, and just a couple of things to know, and that the reason why the angiogenesis story, the blood supply story, is so important in neuroendocrine tumors is they have a unique property, all neuroendocrine tumors, whether they're of the pancreas or the bowel or the lung. They are rich in a blood supply, but these are not vessels that have formed when you were born. They're more importantly the small blood. They're new blood vessels, and that's what Dr. Waldering exploited a long time ago with the effects of octreotide on the new small vessel disease, and that's an important concept that you can't. We're not, and that's the good news about a neuroendocrine tumor. You can. Because of the blood supply, and that probably makes embolization to the liver more effective as well because of the small blood supply and the ability to get spheres or talc into the tumors. So this is a very strong property of the neuroendocrine tumor.
And just to finish up that statement, the infiltration with all types is for this reason. When we see metastases to like brain or to bone, we use alternative therapy in combination. We use bisphosphonates in combination to make sure that we're actually keeping at bay those tumors that don't have a very good blood supply and that we have to stop their growth.
Dr. Waldering, how effective is the black raspberry powder, and is it more effective than valproic acid or verapamil?
The answer to that question is stay tuned. We're working on a clinical trial. It turns out that when we test your tumor, we test it against black raspberry, we tested it against valproic acid, and we test it now against the combination. What we're finding is the combination of the black raspberry plus the valproic acid is really very effective. And we're using when we saw that, we got all excited about the black raspberry and started using it with a whole bunch of other things that all fell flat on their butts. The only one it seems to potentiate is the valproic acid. But the beautiful part about valproic acid is every pharmacy in the United States got it. It ain't rocket science to use. You know, it's used millions of times for seizure control. And so you just add that to the black raspberry powder. And again, non-toxic stuff.
Yeah.
Except it makes people fat.
Yeah.
That's what's wrong with me.
That's, he's been around it too long. That's the problem.
Yeah, it's osmosing out of my lab to get me.
This is a kind of a generic question, a tough one, I think. Dr. Vinnick, if there's no symptoms with a primary in the pancreas, but it's non-functional, and I've been in persons used long-acting repeatable sandostatin 30 milligrams for longer than 7 years, how can one test the progression, that if there's no progression, is it due to the LAR or would it happen anyway?
Okay, that's an interesting question. Non-functioning tumors are non-functioning if you're not measuring the right things. Most of the non-functioning tumors have turned out to be PPMOs, pancreatic polypeptide secreting tumors. You know, if you know the history of gastrointestinal hormones, you'll know that there are hormones seeking functions. There are functions seeking a hormone. There's a tumor seeking a peptide. There's a peptide seeking a tumor. We've tried to marry all these, and it's not been all that easy. Now, one of the things we do know is that when you have a pancreatic tumor that is not secretory, the reason that it can make pancreatic polypeptide and you don't know about it is because pancreatic polypeptide does nothing in the human body. The Lord, as Dr. Waltering says, God gave us that so we could measure it to find those tumors. He gave it to us.
But that having been said, please talk to people about how hard it is to accurately measure PP.
Okay, so it also turns out to be incredibly interesting from the point of view, it's regulated by the nervous system as well, so that if somebody does a vagotomy on you, it stops responding. But I can give you a simple meal test, and your pancreatic polypeptide can rise into the thousands. So it becomes one of the very good markers for what is happening.
Yeah,
to answer the other side of the question,
right.
which is the following, is to say, how would you know after 7 years that somatostatin contained the tumor or that it just behaved really slowly? There's only one way to know.
Oh, don't do it, don't do it.
What's that?
It's actually to do longitudinal follow-up on the people without the drug, and I'm not going there.
Yeah.
I thought he was going to stop the drug.
No, that's the point.
Yeah.
The point is, you don't, because the way to find out is not the way you want to go.
You don't stop the drug.
And there is
don't get off of a horse that's 5 yards from winning the Kentucky Derby.
And that's
it's not time for a coffee break.
And there we have, I'm sure we amongst ourselves must have 5 or 6. And historically what happens is they've stopped the drug and it's recurred. And these are pancreatic tumors that are, quote unquote, as Arthur suggests, non-functional but probably functional. This might be one that I can help with. Can you compare the European protocols, especially detection and radiation treatments, to the loose versus to the looser just treat studies? I'm not aware. They're working on gallium-68 in Europe versus Octreoscan, but there's been no toe-to-toe comparison to see if you can move a gallium-68 scan over to the value of an Octreoscan. And in Europe right now, the criteria still is, it's clinical criteria. They're still using the Krenning classification of the Octreoscan. In actual fact, all the studies in Europe have not been protocol generated, including the Erasmus, the lutetium-177. But 2 of the big players there was Jan Mueller at Gene's meeting in New Orleans, the national one, where he stood up independent of Bob Burka, Richard Baum. And independently, they both said that using the Y90 and the lutetium together, sequentially in reverse order, that their months of progression-free disease was almost a month apart, 59 months versus 60 months.
Yeah.
But it is not protocol driven. That will not be the case in the gallium-68 IMD here, because the two protocols are generated and will be available in the middle of November for the gallium-68. And the phase 3 has not been done, that's for registration. The final step is usually a placebo against the active drug, and it has not been done with the PRRT, the radiotherapy.
Right, but remember, gallium is a scan like an Artria scan.
It's
a diagnostic.
It's a PET, yeah.
It's a PET scan, but it's a diagnostic. It's not a therapeutic. And so, obviously, the question about gallium-68 and how we use it and what it tells us is it going to be a learning curve in the United States for all of us. And you can get mad at us that we're not up to where Europe is, but but we're doing the best we can.
Yeah.
We do have one other advantage, and that is here in the States we're also using meta-iodobenzyl guanidine.
Yeah,
MIBG scans. So when we encounter situations that we're fairly sure that the patient does have a neuroendocrine tumor based upon biochemistry and symptoms, and the Artria scan is negative, we're still doing an MIBG scan. What MIBG offers us in this country is that if you're MIBG positive by criteria similar to the Grinning criteria, that the tumor takes up more than the surrounding tissue, you become a candidate for MIBG therapy.
Yes.
And we just opened an intra-arterial arm where we put the drug directly into your liver rather than giving it intravenously, and that gets the concentration up and hits those liver tumors. But that's only for people with liver-only disease.
Good.
Yeah. And I would just maybe add one more caveat. I've been, because I hang a lot with the nuclear medicine people, and the MIBG is very, very good and a high percent of the time for being positive in midgut ileocarcinoids. The pancreatic ones are much less so. Yeah.
And I got to tell you, our experience with MIBG scans, the percent of people that are positive compared to Artria scans, maybe 30, 40%.
Yeah, and if so,
it's not nearly as good a scan, but when you have a negative Artria scan, it picks up some people that otherwise wouldn't have anything to scan with.
I think the comments by Arthur are especially on bone mets, where the vascularity is going to be, you have a paucity, raises very important questions as to what other kind of tracers we can use to target to target the tumor versus the vessel.
Things about the bone mets that I continue to learn every day. Bone mets are another one of those questions I want to ask God. Bone scans traditionally light up bone metastasis, but in neuroendocrine tumors, you can have a positive Artria scan and a negative bone scan. You can have a positive bone scan and a negative Artria scan, and you can have a negative bone scan, negative Artria scan, and a negative MIBG scan.
There's another scan that is appearing on the horizon now, seeing that we're into talking about scans. It was quite remarkable to go from the first peptide we ever used was insulin. Yeah. And then the second peptide around was somatostatin. And then we learned that you could put a radioactive tag on somatostatin and develop a scan because it bound to those 5 receptors we were talking about. You have another receptor. You have a receptor for glucagon-like peptide 1 or GLP-1, and just published from Europe, and it's in a endocrine clinics that we've just edited here, is that you can take GLP-1 and put a tracer on it, and because there's so many GLP-1 receptors around the body, you can begin to find these tumors. And the first set of tumors have been pancreatic endocrine tumors that have been identified with this new tracer. And so we can anticipate we will be doing that shortly in the United States.
And when we know these genes, you ask the question, what is going to be the value of knowing the genes that are in your tumor? If you have want to know whether you'll be a good candidate for GLP-1, if you don't have that gene in your tumor, you're not going to be a good candidate for that therapy. Yeah. So we're going to take it one step farther. Right now, if you want Artria scan or octreotide PRRT, you get an Artria scan or a gallium-68 scan. But if your tumor doesn't have the genes, you won't even need to do that.
But let me take you a step back, because the way we discovered the expression of some of these receptors is when we did octria scans, and we started showing, Royby showed this originally, we started showing that if you were octreotide positive on a scan, then we got your tissue, and then we found in the tissue that it correlated exactly that you had the receptor. Yeah. So there are different ways to skin a cat.
Yes.
So, the one way you can do the tracer study and see if it's positive. The other way you can look at the tissue to see if it expresses a receptor. The good thing is they correlate pretty well.
Yes, and Royby did do all the primary work at the time. He had done the receptors. He had shown the locks on the tumor. And then Sandoz, now Novartis, made that piece of the native somatostatin, which looked exactly like somatostatin and behaved like it. And then backed into then the next step was the drug, and then the octria scan was developed. They put a label on the octreotide, in a sense, and now that's what they're doing now. They're taking sandostatin modified, and they're putting the radioactive material. It's a perfect story. Jean's work is very, very important. Dr. Sue's doing the same type of thing, except she is looking for the overexpression, and she is now putting pieces on the new genes so we can do diagnostic testing. Melanin-stimulating hormone, calcitonin, and maybe smoothin as well. So, I mean, this is where it's going to be. They're going to be designer peptides for scans and then targeting. But those are a long way off. We have to walk in the United States before we run. And with the new news of the lutetium in Houston, that's good news. Dr. Vinnick, is everolimus now approved by the FDA? And are there any severe side effects? Would you comment as well on Sutent and everolimus?
I'll comment on both of those. Both drugs, strangely enough, are approved for renal cell cancer. Yeah. So we're using that in the clinic already in kidney cancer. Certainly we're using sunitinib or Sutent for thyroid cancer as well. And we've used Sutent for medullary carcinoma of the thyroid. Do you remember I mentioned the MTC, the medullary carcinoma of the thyroid? So we're using it for that as well. The drugs are quite different in their side effects. I had a slide to show you the Sutent side effects, but what you see mostly with Sutent as a side effect is graying of the hair. I have a 13-year-old boy who comes from this area. I don't know if his family are in the audience. I don't see them. But he has a malignant metastatic lipoma, and he comes to me with a different head of hair every time I see him. So because his hair went absolutely gray, and he said he can't walk around with gray hair. So one week he'll have red hair, then the next month I see him, he's got black hair. So he's just trying out the different colors.
There you go.
Yeah, and so he's having a ball with the fact that he's got gray. But that is one, it causes depigmentation, and it's a very striking depigmentation because all the hair on the body goes gray. And then, in addition to that, they also get what is called the hand-foot syndrome, and that is tingling of the fingers and toes, which I think is neuropathic. So we're adding anti-neuropathic therapy when we treat people with everolimus, with sunitinib. Everolimus, on the other hand, has a different set of features. And one of the major things you see there is an unexplained pneumonitis that they get. It's an upper respiratory non-infective type syndrome, and you've got to watch out for it. And you've got to be on top of it because of the marked symptoms it can cause. Yes. It does produce, in some people, diarrhea, and in quite a few people, produces fairly significant fatigue and lethargy.
Mouth ulcers.
Yeah. Mouth ulcers and some weight loss is another.
Yeah.
Dr. Wollering, what type of tissue and transporting needs does your lab need to do the gene testing that you're doing now?
The only way you can get that now is to be operated on at our institution, and we're not charging anybody anything for it. Like all the angiogenesis testing that I've done for the last 5 years, it's all supported by patient donation. When we start offering complete genetic analysis of the genes of the tumor, it'll be transported to the lab in a special tissue culture media on wet ice, not dry ice, but wet ice, like the kind you put in your daiquiri. And you'll basically put the tumor in the tube, seal it up, put it in a baggie full of ice, and send it to the lab.
Here's a question I'll start an answer to. What are the benefits of utilizing CyberKnife in treating nets. There can be some benefit, but with soft tissue of the abdomen, they've gotten so good with CyberKnife now that they can actually release the radiation timed with inspiration and expiration. That being said, and the highly focused energy makes it amenable to thinking, but it's still dangerous because you're going into tissue and soft tissue in the abdomen. It's been effective for us in a couple of retrocrural tumors underneath the diaphragm. We were able.
Spoken like a true non-surgeon.
Yeah, that's
Yeah.
right.
Okay. Don't take your Volkswagen to a Rolls-Royce
Okay.
dealer, and don't take your Rolls to a Volkswagen dealer.
Yeah.
He's a Volkswagen dealer. Ask
Jaguar.
that. Yeah.
Jaguar.
Jaguar. Okay, he's the Rolls dealer. I'm the Volkswagen dealer. In general, take out something surgically when you
Absolutely.
can.
Yeah.
You don't need to do some fancy, hairy-ass 5,200 different ways to radiate your tumor. There are some very specific reasons why to do CyberKnife. Things in the brain, things around spinal cords, things that if a surgeon got in there and mucked about, you would cause more injury than help. CyberKnife is very expensive. It's tens of thousands of dollars, and if you got 100 Mets, to do it at 100 different places is 100 times $10,000. You just couldn't afford it. So it is like any other thing. You can kill me with an arrow, with a bomb, with a hand grenade, a gun, a machine gun, a flamethrower. It's the same way. But you have to ask, why would you use CyberKnife, and why wouldn't you just use cold hard steel? The answer is if cold hard steel wouldn't do as good a job, and that's when you use it.
We share the same experience, because when we have people who have metastasis to bone and it's pressing on a nerve and you're getting nerve damage like that, we need to be dissected out very carefully. We don't want to radiate the area, because the moment you indulge in radiation, you're now radiating that nerve that's entrapped as well, and you produce a whole new syndrome. So this is the time where CyberKnife becomes very important to us.
There are inoperable situations, and that's
Right. Absolutely.
they're truly inoperable. Clearly, it was designed for against bone and very
And brain.
focused and brain.
brain.
The brain
That's where it
tumors,
started.
but the skull and would be a good safe background to hit against. But there have been some, and there is some talk. But again, I agree. CyberKnife is not number 1, 2, or 3 in the treatment for neuro. The question was for neuroendocrine tumors. Here's
And
after,
you can fix my Volkswagen anytime.
yeah. Well, the reason
Just remember, you guys have to remember one thing. Odo and Vinny can go, and we've been friends for 30 years. I mean, Tom's the godfather of my children. I give him more grief than anybody, save my own children or my wife, and vice versa. This is friendly banter. This is not animosity.
They know that.
All right. Well, just so some people say, God, you're so mean to Dr. Odorizio.
He is brutal. He is.
Yeah.
He really is.
I love it. And it's so much fun.
Okay, now there's several questions that are going into the algorithm of care and the options of care, and they're all good. And I intend to take off on page 17 of Arthur's, in the left lower corner slide, 4th from the back this afternoon. So we'll go on that. After debulking, when you think you might be clear, even though you know that it is not true, could taking a low dose everolimus 5 milligrams keep the tumors from growing? Anybody on that?
This is the whole concept
That's
of
exactly
what's called adjuvant therapy, and we've not had any real good trials of adjuvant therapy in neuroendocrine tumors. A lot of people say I had metastatic disease in my liver. I was on LAR. I was on high-dose somatostatin analogs, which are anti-angiogenic, anti-tumor effect. Now I've had cytoreduction. Would I stay on those things, even though I have no proven tumor and I was asymptomatic? And I say, once you're on octreotide, I'd never take hardly anybody off unless they have side effects that just they can't do.
But
But you're thinking the right way.
Yeah.
But we don't have any data. But you're thinking the right way. And that's why we're using things like black raspberry, valproic acid, things that don't make you sick, that are nutritional supplements or things that are used for other conditions that may slow down the growth of these things. And it really makes good sense when you've tested your individual tumor against those agents, and you can see that it works. Right. Then that makes more logical sense. Just to put everybody on low-dose everolimus, when only 13% of the people respond to everolimus, if you're a carcinoid, or 18%, excuse me, if you're a carcinoid, doesn't make a lot of sense, because you're treating 70 people that won't respond for every 100, and only 18 will respond.
Yeah, let me just finish that off a little bit, because what is very typical of both sunitinib, the tyrosine kinase inhibitor, and everolimus, the mTOR inhibitor, is your response rate is about 3 to 4 times higher with a pancreatic neuroendocrine tumor than it is with a carcinoid.
Yeah. Yes.
So that is why I elected to show you the examples today of when you've reached the bottom, when you've already got people on max, you've treated them, you've debulked them, you've got them on somatostatin analog therapy, you've titrated it to the blood level that you want, and it is still getting away from you. That is the time that, even without the trials, we're adding either everolimus or sunitinib. That's exactly what we're doing.
Yes.
And I showed you exactly that.
And what's being talked about is not a prioritization necessarily of therapeutic options, but because all of the options are good options, and I'll say it again this afternoon, but a good option at the wrong time is not your best option.
Sequence is everything.
And a lot of times the orientation with some of the managers that you go to, and I consider myself a manager, Arthur, Gene, are to prefer a clinical trial study, which is very, very good, but you have other options, and you wouldn't want to go necessarily into that pathway immediately. It's as Arthur suggests, when you've done debulking or embolization or surgery as much as you can, or even maybe PRRT before that suggestion. So we'll talk more about it, and I hope you have the same kind of questions, or we can get some of those answered. Now this one catches an edge at the bottom of the ski. How much variation in Ki-67 is there over time? In other words, does the growth pattern change over time? And does resistance change over time? Dr. Gene.
Very good question. I mean, that's sort of like, is there a difference between primary lymph node and that? When we've looked at that in people who've had it over time, biopsy 10 years ago, because it's stable in formaldehyde fixed paraffin embedded tissue, we can go back and look at your Ki-67 from 10 years ago. We can look at your Ki-67 from 5 years ago, and we can look at your Ki-67 from 5 days ago, and that stays relatively stable. That we've been happy with. The resistance stuff, I don't know whether you're talking about somatostatin analogs and the quote tachyphylaxis story. There may be even some friendly disagreement up here. I don't happen to believe in tachyphylaxis. I think that if you start on somatostatin analogs and your symptoms come back, 99% of the time that means you need more somatostatin analog because your tumor's growing. If your tumor makes something at the rate of X per gram and you go from 1 gram to 1,000 grams, you're now making 1,000 more X's. And you may need more drug to make 1,000 more X's go away.
Well, and that was one of the comments on the PROMID study, because they used the standardized 30 milligrams every 28 days, and they've got what you saw, Arthur showed the PROMID results, but in actual fact, one of the criticisms was they didn't use enough, or they would have had a better durability. But in fairness to Gene, he was one of the first to say more is better, and many of some of the international folk disagreed. But in fact, more is better. Arthur had a comment.
All right. I just want to take this issue a little further because the question has other ramifications. Does the Chi-67 change over time? But what does change very dramatically over time is what I was alluding to earlier in my talk, is that if we start seeing the production of a tumor starts producing ACTH or it starts producing calcitonin, we know that there's another clone of cells that's operating and it's behaving quite differently. And that the original behavior can be very static over a long period of time, and then we get this breakthrough of the new clone.
Yeah.
Now it behaves in a much more aggressive, much more malignant, and we need to go after it. And we don't have the data to say that that is expressing more, Chi-67, but we do have the data to say it's a different clone. The original tumor was maybe producing serotonin. This one's now making calcitonin, and it's making gas.
And that really does happen,
it's
guys.
bad news. It does happen.
And the other thing you need to know is basic geometry. And I hate to do this to a crowd because I hate thinking about high school. But if one cell becomes two cells, that's called a doubling time. And let's say that's 3 months. How long does it take to go from one baseball to two baseballs of tumor? Same amount of time. How long does it take to go from one Empire State Building to two Empire State Buildings full of tumor? Same amount of time as one cell going to two cell. If I tell you a cell is smaller than a fly speck and it takes 90 days, let's say, to become two fly specks, you say that tumor is growing incredibly slowly. But if I tell you you have to build two Empire State Buildings in 90 days, there are not enough steel workers in the United States to do that. That's the fastest growing tumor you've ever heard of. It's the same tumor. It's the same exact geometry. It's called a Gompertzian growth curve. So this is why the old people in the South used to say, if you open up grandma and you expose her tumor to oxygen, to the air, it takes off like a son of a gun. No, they didn't operate on grandma till she had a tumor the size of the eggplant that ate Chicago. And so now she has a tumor this big. In 90 days, she has a tumor this big and she's dead. It had nothing to do with oxygen. It has to do with geometry. So remember, your tumor grows at a given rate, but the bigger the tumor, the more rapid it appears.
That's a good point. So something like CAT scans, and it turns out that at this point in time, the gold standard for decision making changes of the options really is a CT or MI, because the CT does mark the size of the baseball here and the size of the the softball in a progressive time.
In 6
and that's
months,
in
right.
6 months, and that's how you mark, and that's how decisions are made as to what you do next. Arthur?
I don't want to be a dog in the manger, but you see very interesting things. When you start treating people with drugs like somatostatin, like sunitinib, like everolimus, and they affect blood supply, you can see a tumor that looks this big, but the whole of it is dead.
Necrosis.
It's like I
dead.
call it the black hole of Calcutta. Because basically what you're watching this tumor, you say, oh, the size is increasing, this is terrible. And then you go and see inside that tumor, it's eaten up the whole inside. So just bulk.
There's
is
a
not
way
easy.
that you can actually measure that. It's called a Hounsfield unit on a CAT scan. And when you do PRRT, one of the things that we saw with PRRT, exactly what Arthur says, your tumor 9 months later is still the size of a grapefruit. But the Hounsfield units went from iron, solid as a rock, to water because the whole inside died. And necrosed. And just remember, I always tell people, if you walk over to a tree and it has an apple on the tree, that apple's alive. The minute you pick it, it's dead. Now you hold it in your hand, and a month later, you still got something that you can recognize as an apple. It don't go poof. Same way with a tumor that you kill in the body. The body takes time to clean up the tumor and get rid of the tumor. And that may take a year in some of these therapies.
Yeah. The whole phenomenon of autonecrosis, and we've seen that. Arthur and I see it often with pheochromocytomas, where the catecholamines, the adrenaline is so high that there's a constriction of the small vessels inside the tumors, and they necrose from, and they
And so you will see in reports, when you read reports of how people do, they use what they call RECIST criteria, R-E-C-I-S-T, RECIST criteria. And that really is, you do the measurements, and we all do these measurements ourselves. It's required that the principal investigator takes out a ruler and measures every single tumor. And it lies to you because the tumor may look the same size, but it hasn't. It's undergone all this degeneration. Yeah. The patient's better, the biochemistry's better, everything's better. So be careful when you read them.
And the FDA don't let you use that as a response. If the tumor is dead as a smelt, it went from a solid tumor to a totally liquid ball of water, the FDA, and your markers came down by 80%. The FDA won't count that as a response because the outside of the tumor is still 8 centimeters in diameter, and it didn't change.
And I would just add to Gene, the CT Hounsfield units are very, very accurate, and they take time to do, but it's worth doing in a serial manner in the same instrument, same locale each time. We tend for the liver, for liver lesions, we use what they call a Doppler ultrasound, which is just an echogram with a grayscale reading. And what that can literally do, they can actually hear the resistance of the tumors and estimate relative tumor burden, which, if done carefully in the same by the same last Swiss watchmaker of the world, is perfect, because he's the only one that seems to be able to read these things. But they use a contrast now, which is, instead of angiographin or iodine, they use tiny little bubbles, and they can determine just what Gene is saying, how much of it is alive and well tumor versus how much is necrosed.
That's cool.
Yeah,
that's beautiful.
Yep, it's very.
That would be very cool.
One last question, and we'll stop. Has there been any head-to-head trials between sandostatin and somatulin, octreotide, or lanreotide, as it's called? The only studies I know, and Arthur can correct me, are the European studies with acromegaly. Now, they were never really a head-to-head. They used their maximum dose recommended for growth hormone secreting tumors of the pituitary. And even though if you look very, very closely, the response seems to be a little bit better with octreotide, and the binding data would suggest the same thing in vitro. If you do binding data, octreotide has an edge, although they're, for all practical purposes, identical in terms of their action. Lanreotide sees 5 a little bit, receptor 5 a little bit better, but in terms of the question, I don't. They were equally potent.
Just remember that Dr. Odorizio is quoting the doses of somatulene and octreotide are not the same. No. 30 milligrams is not 30 milligrams. Okay, it's like penicillin versus tetracycline. They're not the same. You can't compare them. So what you have to do, guys, is you have to measure a blood level. And so this is where you're screwed, blued, and tattooed right off the get-go, because they use 30 of octreotide, and that gives you X blood level, and they use 60 of somatulene, and that gives you Y blood level, and they're not the same blood levels. And nobody's controlling the tests, even within a drug like LAR, by blood level. And that's where we're trying to go. That's why when you read what I write, a lot of stuff I'm recommending, if you're not responding to LAR, first thing you ought to do, don't screw around with your dose. Go get objective evidence that you don't got enough of the drug in your blood. It's a simple blood test.
Okay.
Arthur has a comment.
So
we'll stop.
Let us go back to what you were hearing about earlier, and because there's a lot of data on acromegaly in Europe. So the studies were done by McCarthy and Rusnevsky, and the way they did the studies was not to do simply head-to-head. What they did was crossover studies. So if you were on lanreotide, you were crossed over to octreotide. If you were octreotide, you were crossed over to lanreotide. And then what they looked at is response rates. Now, you'd expect if the drugs were identical that the response rate should be identical, and that's not true. And what happened is, as Dr. Aurizo pointed out, is the responses to octreotide were a little better, but there were cases and case examples that responded to the one and not to the other. So that it doesn't mean that you must eliminate it. Right now, we're doing a worldwide study, and we're doing the study is in somatostatin octreotide failures. Will they respond to lanreotide? And that is the study we're doing worldwide.
And the problem with the study is, again, we're not making dosing decisions based on blood level. We're making dosing decisions based on commercial. How can I say this without being a total ass? Commercial considerations.
Right. And just to finish off that point, as a group, we did go to one of the major companies to say we wanted this group a head-to-head study, including Bill go over there, and they said yes, we'd like you to do that, but we think your study is too expensive, so we're not going to fund the
total cost of the study. Remember, this is a $1.2 billion a year drug. Octreotide is LAR, $1.2 billion a year. The study costs $7 million to do. I mean, 0.07%.
And about $6.5 million was going to
I said
Walter
that's the sweat. That's the sweat off of your bank account. This is a company that had $30 billion in the bank. I said $7 million to do this study, and know what we're doing with this drug is a nonsense number. And they still thought $7 million was too expensive.
We'll send
to spend.
another negotiator.
We said now we've got all of you on our side, and we want you all to write letters.
Write letters.
Thank you very much.